literature this week. The image in the New England Journal is this one. It's an MRI of a brain. It concerns an 18-year-old man who presented to the department with generalized tonic and clonic seizures. I guess we can tell why. The brain is literally filled with fairly homogeneous, same-size looking excrescences scattered throughout the gray and also the white matter. And with this history of seizure disorders, we're offered cerebral metastases, progressive multifocal leukoencephalopathy, cerebral vasculitis, neurosyphilis, and neurocystecircosis. Well, the diagnosis is obvious. The first four things play no role here, and this is an example of neurocystecircosis. It's caused by the hog tapeworm Teniasolium, and we'll look at details in a moment. So, the differential diagnoses also included brain metastases. These can be multiple, spread throughout the brain, but they differ in size and they certainly differ in their presentation. This is only one example. That's not what today's diagnosis is. Here's an example of multifocal leukoencephalopathy. This is a viral disease that involves white matter. It appears in patients that are immunosuppressed, including those treated with rituximab or natalizumab, which is directed against a surface molecule of immune cells. And JC virus is a DNA virus. It's JC stands for the initials of the patient that first had it. Looks entirely different. Here's an example of vasculitis. It can be, this can concern blood vessels of various sizes, various manifestations. We would expect perhaps several lesions that are not homogeneous, spread in different parts of the brain along a vascular distribution. That's not the case in the patient today. Neurosyphilis is an infectious disease, small organisms. Neurosyphilis can certainly cause changes on magnetic resonance imaging. The arrow here concerns a brainstem lesion, looks entirely different than what we're dealing with today. And here's an example of cystecircosis. You'll recall that the pig tapeworm can be acquired through ingestion of cystic lesions that are spread in skeletal muscle and other tissues of the pig. If this isn't cooked properly, then humans get the tapeworm. And the tapeworm obviously lays eggs and also discharges proglottids. One can become auto-infected by the proglottids, which results in these cystic lesions spread throughout the body. These are disaster, but fortunately this is a rare disease today. The first topic in the New England Journal is renal cell carcinoma. This is a fairly common cancer in adults, a little more common in men than in women. Renal cell carcinoma is commonly picked up today as an incidental finding through the imaging that's available today. And if excised early, this is usually the end of the problem. But if the carcinoma increases in size, spreads, metastasizes through the vasculature, commonly the renal vein, or through regional lymph nodes, then this becomes a lethal disease. And the chemotherapeutic options for renal cell carcinoma are unsatisfactory. Now, the treatment today involves PD-1 and PD-1 ligand. I want to remind you of the fact that programmed death 1 is a protein. It's a receptor. So PD-1 is the receptor, and PD-1 ligand is the ligand. And the ligand is expressed by tumor cells. It addresses the receptor PD-1, which is present on T cells, which ameliorates their aggressiveness. And the strategy is to break this amelioration by antibodies. And the products that have been developed are antibodies against the receptor, against PD-1, and also antibodies directed against PD-1 ligand that's expressed on the tumor cells. That's the topic. In the first study, we're dealing with avelumab. Avelumab is an antibody against PD-1 ligand. We've seen other studies where sunitinib, which addresses a number of tyrosine receptor kinases, including the VEGF receptor, has shown activity against renal cell carcinoma. And the strategy in this study is to not only block VEGF receptor signaling, but also to address this ameliorative pathway consisting of PD-1 receptor and PD-1 ligand. Now, avelumab is an antibody against PD-1 ligand, and the patients here were randomized to treatment with sunitinib alone, or as an alternative, avelumab plus axitinib that also addresses VEGF receptor. Look at the patients. Looks like the randomization worked. Mostly men, some women, variable degrees of tumor spread, various scales to look at the prognosis, geographical distribution, previous nephrectomy. Commonly this is performed, yes, in 80% of the patients. So the randomization worked. Now, if we look at the course of these patients treated with avelumab plus axitinib, progression-free survival in patients that expressed PD-1 ligand is better in the avelumab axitinib group than it is in the sunitinib group. The same was true in the overall population. Exactly why the expression of PD-1 ligand doesn't seem to be necessary in some patients is not entirely clear to me, but perhaps experts in cancer treatment can elucidate that. But I believe that this phenomenon is relatively common in these studies, that the expression of PD-1 ligand on tumor doesn't appear to be necessary for the treatment to be effective. So if we look at this information provided in a tabular fashion, you can see here, and the distribution of complete response, that means diminution of the tumor, partial response, stable disease, progressive disease, looks like that's in favor of avelumab plus axitinib compared to sunitinib. And if we look at these waterfall diagrams here, it looks as if the response of the patients with the combined therapy is a little better than the patients with sunitinib alone, although the group with sunitinib alone shows in all a favorable response. And if we look at various subgroups here, these responses were similar in a variety of subgroups, independent of age or geographic status. This difference between men and women is not statistically significant. Body mass index, smoking status, etc. had no effect. If we look at complications or adverse events, we would expect hypertension from inhibition of VEGF receptor, and we would expect hypothyroidism as one of the endocrine adverse effects related to PD-1 ligand antibody, and these items occurred in increased amounts, but apparently this was relatively tolerable. However, if we look at overall survival, it was 11.6 months in the combined avelumab plus axitinib group and 10.7 months in the sunitinib group. This is a difference of about 4 weeks, and it's not statistically significant. So that result is rather disappointing. However, we move to the next study, same story in essence. This time we have pembrolizumab, and pembrolizumab is an antibody against the receptor PD-1 instead of PD-1 ligand. Axitinib again is present in this treatment strategy. Again, sunitinib as the control group. Again, we look at the patients here. Older patients, 75% male, spread throughout North America and Western Europe. Their prognostic risk is also distributed in both groups in a similar fashion. The expression of PD-1 ligand, again, is present in about 60% of patients, but not in all. And the presence of metastases were distributed adequately in the two groups. And if we look at overall survival, here there is a benefit of the group that got antibody to PD-1 receptor, and as opposed to the group that got sunitinib alone. The difference here is about 10%. I guess I'd rather be in the blue group than in the red group, but this is certainly not a cure for cancer. If we look at the forest plot here of various subgroups, again, all groups seem to profit from this treatment. And if we look at progression-free survival, it looks similar to the previous study. Now, if we look at these data in a tabular fashion, it's pretty much the same as the diagram. Progressive disease was more common in the sunitinib group, underscoring the advantage perhaps of this combined treatment. And if we look at complications, again, hypertension and hypothyroidism occur as we would expect from these agents, with a whole host of other things, but on the whole, it looks like the treatment was fairly tolerable by these patients. So in this trial, the combination of VEGF receptor inhibition with axitinib plus an antibody, in this case against the PD-1 receptor rather than PD-1 ligand, resulted in not only an increase in progression-free survival, but also overall survival. There was an editorial on this, and we can have a look at that because the editorial includes another study using nivolumab, which is also an antibody against PD-1 receptor. And if we look at these tabular data here, it seems to be that this combined therapy of VEGF receptor tyrosine kinase inhibition plus some approach to deal with PD-1 ligand, PD-1 interactions seems to improve the outlook for patients with advanced renal cell carcinoma. The next topic is attention deficit hyperactivity syndrome. This is a spectrum of disease. In the meantime, this is probably the most common chronic disease of children, I suppose, at least in terms of prescriptions that are rendered for this condition. This all began about 50 years ago. I remember I was a military pediatrician when treatments for this condition were first introduced, but treating attention deficit hyperactivity syndrome has become a major clinical endeavor. Now, the problem here is that psychotic events occur in patients with attention deficit hyperactivity disease. Psychotic events also occur in the general population, but the possibility exists that treatment for ADHD might stimulate the development of psychotic events because methylphenidate and the other compound that's given for this condition nowadays, an amphetamine derivative, could conceivably increase the amounts of psychotic events. So what was done in this study, this is a huge registry study, actually two studies in one involving insurance carriers that pay for these prescriptions. This registry approach enabled the investigators to look at the occurrence of psychotic events in children that are treated with amphetamines compared to those that are treated with methylphenidate. And indeed, the amount of available dopamine is substantially greater with patients treated with amphetamines than those treated with methylphenidate, underscoring the possibility that perhaps amphetamines might cause more psychoses to occur than methylphenidate. So Optimum Clinformatics database compared to IBM Market Scan database. There are massive numbers of young people here that were inspected. That results in statistically significant differences, although the means are trivially different. And what these statistically significant differences mean in this study, comparing 18.9% to 19.2%, highly statistically significant, I don't know if this means anything clinically, but if we look at these distributions, they seem relatively similar in patients that are treated with methylphenidate compared to those treated with amphetamines. And here's what's happened to prescribing. So methylphenidate is in green, amphetamines are in blue. And if we look at the age spectrum here, it seems that the clinicians, particularly in older individuals, favor amphetamines compared to methylphenidate. And if we look at the prescribing patterns from 2005 compared to 2015, there's a substantial increase in amphetamine prescriptions compared to methylphenidate prescriptions, which actually look fairly stable across this time period, indicating that more and more patients are being treated for this condition, and commonly with amphetamines. Now, if we look at the primary analysis and sensitivity analysis, etc., we see that psychotic events occur with both treatments. I don't think that they're massive in number. I'm not really qualified to judge that, but psychotic events occur. But they are about twice as frequent in the patients getting amphetamines compared to methylphenidate. So the percentage of patients, 0.1% compared to 0.2% is a 100% difference, relatively speaking, but the episodes of psychoses, in my view as a non-psychiatrist, seems relatively modest in these patients that, because of their underlying condition, might be prone to psychotic events were they even not treated. The next topic is pulmonary embolism, and this topic has advanced substantially in the last 30 years. Pulmonary embolism is lethal. We commonly diagnosed it at autopsy, eventually angiography, which is difficult and technically demanding and logistically extremely difficult to get done in a hospital, was the only method that we had in order to diagnose massive pulmonary embolism pre-mortem. Subsequently, nuclear medicine got into the act, providing lung scans, which were available generally during the daytime, less so at night, but they were often not very definitive. So the radiologist would say, pulmonary embolism can't be ruled out. That's nice. But the development of spiral CT dramatically changed the diagnosis of pulmonary embolism. And that's been a great advance, and an example is shown here in this transverse CT here, and we can see the massive pulmonary embolism here in this right pulmonary artery in this patient. Now, we don't want to send everybody to CT, and so scales have been developed largely in the Netherlands that are helpful in this regard. And one of them is the Wells scale. Previous diagnosis of deep vein thrombosis. Are other diagnoses more likely than pulmonary embolism? Has immobilization occurred? Has the patient already had an earlier episode? Is the patient coughing up blood? Does the patient have cancer? These kinds of risk scores helped considerably. Another thing that might help is D-dimer testing. And D-dimers are breakdown products of fibrin, which is cleaved by plasminogen, as you know. And these breakdown products can be tested biochemically. And they're also helpful in establishing the diagnosis. So, again, an earlier study conducted in Holland called the YEARS study combined three variables with D-dimer over a certain level to decide whether or not the patient should be sent to CT. And this has been a substantial improvement in diagnosis. So the variables are clinical signs of deep vein thrombosis, history, physical examination, some simple measurements with a tape measure and looking for Hohmann sign and other clinical parameters. Is the patient coughing out blood? Is pulmonary embolism the most likely diagnosis, or are other things possible, such as trauma or what have you? Those are the three variables combined with the D-dimer testing. And now the YEARS algorithm has been expanded to pregnant patients because pulmonary embolism in pregnancy is, aside from preeclampsia, one of the leading causes of maternal death in the Western world. So the decision here is, does this pregnant patient have a risk for pulmonary embolism high enough that we're going to send her to CT, which is a substantial radiation burden for mother and fetus, or are the chances so minor that we don't need to bother with this? And are there differences in the first trimester, second trimester, and last trimester? So if we look at this diagram of the decision-making algorithm here, no YEARS criteria. In other words, the answer to the first three questions that I ask is 0. Übertragung läuft, Aufzeichnung, guess it still works. In that case, no CT. But if the D-dimer level is greater than 1,000, or if one of the three questions is answered with yes, and the D-dimer level is less than 500, and one of the three questions is answered with yes, but the D-dimer level is greater than 500. So this is the decision tree for either no CT or perform CT. And you can look at this thought diagram in detail on your own. So that's how the study was designed, and then the patients were followed to see if they had eventually ended up having concrete evidence of thromboembolism or not. So if we look at these patients, there are 498 pregnant patients that were studied here in the various trimesters. The YEARS criteria with these three questions were applied. Is it first pregnancy or subsequent pregnancies? Did the lady smoke? Did they have asthma, previous thromboembolism, etc.? And if we look at the ones that where the decision was CT pulmonary angiograph not indicated, the number of pulmonary embolisms confirmed at baseline is 0. CT indicated, the number of pulmonary embolisms 16. And if we look at first trimester, second trimester, third trimester, the testing is most effective in the first trimester, drops a little bit off subsequent to that time. But at any rate, the YEARS algorithm can be applied to pregnant patients, and on the basis of the D-dimer levels, decisions can be made in a sensible fashion whether or not CT angiography should be applied or no. And with this algorithm, we can avoid 39% of the CT angiograms that would otherwise be performed. So this looks like an advance. Small paper, brief report in the New England Journal, rather envious about this, concerns vitamin D. You'll recall that vitamin D is the sunshine vitamin, and with 7-dehydrocholesterol that's produced in the skin, the liver can hydroxylate this at the 25 position to make 25-hydroxy vitamin D. which is then hydroxylated in the one position to make the active compound of vitamin D that has a major effect on bone, gastrointestinal tract, other organs to promote bone mineralization, phosphate and calcium absorption, etc., to maintain a healthy skeletal. What we probably don't appreciate as much is vitamin D doesn't lie around loose in the plasma. It's bound to vitamin D binding protein. And the amount of free vitamin D is an equilibrium between the vitamin D that's bound to vitamin D binding protein and the amount that's free in the circulation. So what happened here in this study is a poor woman, 58 years old, who also has ankylosing spondylitis, that's not important to this report, was observed to have severe vitamin D deficiency. And the vitamin D deficiency didn't get any better. And it turns out she is a compound heterozygous. That means she has two deletions that lead to deletion of the GC gene, which is the group-specific component gene that encodes vitamin D binding protein. And that's what this story is about. And so if we look at this lady, she's Lebanese parentage, and her parents are heterozygous for these two deletions that I'm going to show you in a moment. Got lots of siblings. Some of them are heterozygous as well, but she's homozygous because she got one deletion from mother and the other deletion from father. And if we look at her lab values, they're actually pretty normal. Her phosphate is commonly on the low side, but not as low as if she had an FGF23 problem. And her calcium levels are actually normal. And her parathyroid hormone levels are commonly normal, but they sort of go up and down. And alkaline phosphatase is generally within the normal range. So if we look at her deletions, one that she got from mother and the other that she got from father, she harbors two deletions. And if we look at this FISH analysis, if you look carefully here, she's only got green dots. Her heterozygous sibling on one chromosome has a red dot, and her homozygous normal sibling has a red dot and a green dot on one chromosome and a red dot and a green dot on the other chromosome, so he's okay. And if we look at her vitamin D levels, 25 hydroxy, total vitamin D, 125, etc., compared to normal, these values are all low. And then if we look at what her cells do with this vitamin D without the binding protein, they don't behave normal either. And I'm happy to be able to tell you that the knockout mouse that's been around for some years also looks like the patient. So this is an example of absence of vitamin D binding protein. Also has to do with thinking about magellan resorbing vitamin D that's bound to vitamin D binding protein via the magellan receptor and how important that is. So at any rate, this homozygous deletion of GC gene in this patient was associated with a relatively mild phenotype. So much for that. Now this next paper, which is published in the New England Journal under the rubric of Medicine and Society, I really don't understand at all. But it involves Plan S, which is to be decided by the EU in short order, demanding that all publications by funded EU investigators be under open access. And this causes some immense problems. And I don't understand any of this, but I've been involved in being an investigator. I published my first paper 45 years ago. And it went basically like this. I had to get a grant, taxpayers' money. My salary was paid by taxpayers' money. I did a study. I turned the data over to a publisher that paid nothing for any of this. The publisher, with some gnashing of teeth, eventually published my paper that got at that time we didn't have impact points. Those are something more recent. But with this publication, I was able to write more grants, generate more money. My employer got indirect costs, and I've been running on this treadmill ever since. So I think medical publishing is a remarkable industry in that they don't develop the product. That's done by people running on treadmills. They don't pay for the development of the product. They don't provide granting for research. They seem to just get the profit from research. And what's happened in the last years is giant companies have developed and have bought major journals with lots of impact points. Elsevier, Springer Nature, Wiley Blackwell, Taylor Francis. I included New England Journal of Medicine group on my own. It wasn't mentioned by the authors since that's the most powerful medical publisher on the planet. This is a remarkable business model. And what's happened is that these publishers demand money, not only from investigators to publish this stuff. We have to pay publications cost, we have to pay for illustrations, even though we deliver the product almost ready for print, complete with color illustrations and everything. This is a remarkable business model. And since at my institution, Elsevier has demanded substantial sums from my medical school so that we have access to the Lancet, Cell Press, and other journals, my medical school says they can't pay it, despite the indirect costs that they get from my running on the treadmill and everybody else running on treadmills. And that's probably responsible for this Plan S principle, and you can look at that on your own. This issue really isn't discussed by this author, but I thought I'd give you my 2 cents worth since I've been running on this treadmill for almost 50 years. What's happened in the meantime is the development of internet trolls, and we're continually bombarded with emails for probably bogus publishers from other so-called journals that I've never heard of before, where they also want publications costs because they must be very interested in this remarkable business model. Don't worry, be happy. And then there's the business about copyrights. You know, I feel kind of sorry for Mozart and Franz Schubert and Frédéric Chopin. I feel less sorry for rock stars. And I don't know if I should feel sorry for myself, because it never occurred to me that science is like art and that my publications should have a copyright. Why should they? Some lawyers have decided that they have to. And so now there's all this copyright stuff, and the EU Parliament voted on this yesterday. I don't understand a word of it. But probably the fact that this exercise also appears in YouTube is against the law. And I'll be hearing about that shortly. The review in the New England Journal is on Helicobacter infection, and this is a remarkable development over the last 30 years. It's the case vignette is a 32-year-old woman emigrated from Eastern Europe, where Helicobacter is more common than Western Europe. She has a serum test for Helicobacter pylori. It's positive. And she has symptoms, and she gets omeprazole, amoxicillin, clarithromycin, supposed to take that for 10 days, and she doesn't get any better. And so what should we do with this patient? And this is a worthwhile review telling you how we approach this problem today. And one of the first things that we learn is that serum testing for Helicobacter pylori is worthless. So we have to rely either on direct biopsy in patients where endoscopy is indicated, and in those patients where endoscopy is perhaps not necessary, then a stool antigen test can be done, or the urea breath test can be done, which requires more equipment and is fairly expensive. But serum testing for Helicobacter pylori, you can forget it. Now, who should be endoscoped? And who should be perhaps evaluated with non-invasive tests? And non-invasive tests, long-term aspirin users, non-steroidal anti-inflammatory drugs, unexplained iron deficiency, immune thrombocytopenia. Those are the things that are listed here. Other complaints where endoscopy is clearly indicated, then a biopsy can be done to look for Helicobacter. Now, there are numerous regimens here, and it's impossible to memorize these, but if you deal with this problem every day, then you can look at this in detail. One of the things that I think is interesting is doxycycline is not a substitute for tetracycline, which works better against Helicobacter than doxycycline. Learned that also. So those are the conclusions and recommendations. So if you deal with these patients, and most everyone does, I would suggest that you look at this review in detail, because Helicobacter is now, as we recognize is not just a problem with malt lymphoma, it also is a risk factor against gastric cancer. And PPIs should be discontinued during testing, but histamine 2 receptor blockers can be substituted instead. Here's a patient now, the New England Journal. This is a lady that complains that she's getting darker all the time, although she's not in the sun. Malignant melanoma was diagnosed some 8 years earlier, and suddenly her urine has this melanotic appearance. And this is spread of malignant melanoma. The exact mechanism is unknown, but this phenomenon is thought to involve cytolysis of melanoma cells, leading to the release of large amounts of melanin, so enough that it appears in the urine, and this poor patient died 2 weeks after presentation. Then there's a small social vignette in the New England Journal. It concerns migrants. And this is a major social issue in the United States, and Donald Trump wants to build this wall. But a lot of migrants come to the United States to work short periods of time, and then they go home again. They come to the United States to pick strawberries, for instance, and then they move from one strawberry field to another, similar to workers that come to Germany to pick asparagus. They don't come here because it's so great. They come here out of economic reasons so that they can pick asparagus and then go home. If they have a medical problem, first of all, these people are not medically insured. So if they're cared for at all, they might show up at a community health center that's supported by kindly people, certainly not the government. And the issue here is about Mrs. G, who's 39 years old and pregnant again. Her 12-year-old daughter recently committed suicide in Mexico. But she moves from one workplace to another, and so her prenatal care, even though for her she's not being charged for it, she's not eligible for U.S. care, but at least it's rather spotty because she has to move from one place to another, and these social issues are discussed in this small vignette, which involves social distance and mobility. And this was the patient from last week with Lemierre syndrome. And what we can see in this CT is these cavities here. And this is his blood culture, showing that these gram-negative bacillary forms that exist in chains, and which is typical for Fusobacterium necrophorum. And he's also got thrombosis of his jugular vein here that's shown by this arrow. So that's Lemierre syndrome, and that's a medical emergency. Then the patient in the New England Journal concerns a 62-year-old man with atrial fibrillation. And he has psychiatric problems, and he also has an alcohol problem, and he's treated with a variety of antidepressant drugs and perhaps some other agents. And here's his electrocardiogram, and he's got atrial fibrillation with a heart rate that's certainly faster than 100. He's going at 130 beats a minute. And because he has a near syncopal episode and sinus pauses of 6 to 7 seconds, he also gets a pacemaker. That's helpful in considering what's going on in this patient, although he probably doesn't really need this pacemaker. And so what we learn here is the interrelationship between medical conditions that favor the development of atrial fibrillation and psychiatric conditions that also have an influence on the development of atrial fibrillation, including the medications that these patients receive. Hyperthyroidism, he doesn't have that. Recurrent atrial fibrillation, he certainly has that. At least initially, he doesn't have evidence of dilative cardiomyopathy. Is he at risk for torsade de pointes? If he gets medications that prolong the QT interval, he might be. Other medical causes, panic disorders, substance intoxications, and this patient has a high alcohol intake, and that leads to atrial fibrillation. Substance withdrawal is considered. And we learn that recurrent atrial fibrillation in the context of general anxiety disorder and major depressive disorder is common. And his pacemaker enables us to look at what happens during some of these episodes. And analysis, we can look at, the pacemaker serves as an event recorder. And during one of his episodes of atrial fibrillation that's associated with an anxiety attack, we can look at his atrial rate, and it looks like it's about 350. And about every third or fourth beat gets transmitted to his ventricles, and here atrial fibrillation. And so the pacemaker allows us to have an electrical window so that we can record this event and associate it with his psychiatric well-being. He's eventually treated with sotalol and gets some better. So an example of psychiatric medications, risk for arrhythmia, psychiatric conditions, medical conditions, and how all these problems interact in a given patient. There's a question from the New England Journal. Which type of cancer is associated with hypercalcemia? And we're offered mesothelioma, squamous cell carcinoma of the lung, small cell cancer, thymoma, adenocarcinoma. I guess they're all possible. But small cell carcinoma is a neuroendocrine tumor that's associated with ACTH and antidiuretic hormone production. And the correct answer here is the most common cause is squamous cell carcinoma of the lung resulting in parathyroid hormone-related peptide release. So much for that one. Chlorhexidine is an antiseptic medication, and currently it's the most effective antiseptic that's available, and it has this wonderful structure shown here. And it's widely used in medicine and in dental care, etc., and it works pretty well as an antiseptic. We know that patients that are treated in intensive care units, if they're treated with chlorhexidine, routine bathing, and mupirocin ointment, that the spread of toxic organisms, methicillin-resistant Staphylococcus aureus and vancomycin-resistant enterococci is reduced. Is this principle also translatable to other wards in the hospital? And that was the question that was asked in this Lancet study. So these are non-intensive care unit patients within hospitals, whole host of various diagnoses here. And they're randomized to chlorhexidine and the ointment against MRSA compared to soap alone. And what we see here is that in general terms, there's no benefit. But if we look at some subgroups, looking at MRSA and vancomycin-resistant organisms and positive blood cultures for these things, then we see an advantage to this treatment. So in the overall population, maybe it doesn't make a significant difference, but in terms of dealing with MRSA or vancomycin-resistant organisms, cyclohexidine and the ointment seems to be an improved strategy. How long that lasts, we'll have to wait and see, although chlorhexidine has been around for a while and it still seems to be effective. Can we get patients to be more compliant if we give them a smartphone? This hypothesis was tested in patients that are being treated for tuberculosis. And we know that to get patients to be compliant, you practically have to watch them yourselves, watch them swallowing the drugs. Now, could the person watching them be substituted by a smartphone that has an app that records whether or not they took their pills or not? That was done here. And the participants here got a Samsung Galaxy, not bad. And they were randomized to direct observed treatment and video observed treatment. Now, the patients had to have access to an electrical plug. So if they're living underneath a bridge where there's no electrical plug, then they couldn't participate in the study. And if we look at this, not observed and direct observed, the smartphone seems to do pretty well. I'm not certain why. But perhaps the patients were so involved with their smartphones that they were more compliant than showing up for direct observation. So if we look at intention to treat, it looks pretty good for patients that were observed with smartphone compared to the ones that were willing to be observed with direct observation. And so I guess if your institution can afford it, we can buy a smartphone for these patients and expect better compliance. Then we know that medically assisted reproduction results in infants that are smaller at birth weight and they have more medical problems. And the question is, does this have to do with the conditions that result in the necessity for medically assisted reproduction, or does it have something to do with the technical aspects of the procedure? This was tested here in this very interesting Finnish study where one could conduct between family, comparing one family to another, family that had this procedure done or didn't, compared to within family, where one child was born with assisted reproduction and the other child was born under natural circumstances. So tabular data are given here. You can inspect that on your own. If we look at within family and between family, the within family differences are narrower, but they still exist. And this difference implies that it's not the procedure, but it's something that has to do with the necessity of the procedure, resulting in these more complicated outcomes of these pregnancies. And that was concluded by these authors. Now, the next paper in the Lancet is on anal incontinence. And does cesarean delivery compared to vaginal delivery provide some protection? And I guess it does. And so you can look at in this large registry of incontinence occurs more commonly after vaginal delivery. But if you pick your patients clinically carefully, you can pick the ones that might benefit from cesarean delivery compared to vaginal delivery in order to avoid anal incontinence at a later age. And that's all worked out here in these diagrams. So, elective cesarean delivery is increasing rapidly in all countries, and that has some impact on subsequent anal incontinence, but that's not a reason to necessarily favor elective cesarean delivery because there are other variables that need to be considered. The review in the Lancet concerns epithelial ovarian cancer and the genetic causes for that and the various histologies that are involved here and the possibility of understanding the disease, the development of some sort of biomarkers, because an early diagnosis would obviously markedly improve the outcomes. We've looked at studies where screening procedures have been done with ultrasound, which was not very effective as an earlier diagnostic procedure. There are various criteria that have been developed, patient characteristics. In addition to BRCA1 and BRCA2, there are a whole number of other genetic causes that favor the development of ovarian cancer. Histological considerations here, and again, PD1 and PD ligand, PD-1 ligand show up again, and I'm sure we'll be seeing studies in terms of that mTOR pathway and the possible development of mTOR pathway inhibitors or MAP kinase pathway inhibitors as treatments, and everything that you need to know about that disease. The last study we'll look at is this one. It looked at activity in 88,000 Americans. This is an N Haynes derivative study. And if we look at these people here, they were divided in terms of their activity, physical activity in terms of minutes per week. Some of them are fairly active. It's only 2,500 of the total of 88,000. What interested me is of the 88,140 participants here, 36,702 do not move at all. And then there is a degraded increase, a variable graded increase in physical activity of these people. And that's pretty much independent of whether or not they drink and whether or not they've ever been married and how far they went to school and this sort of stuff. But what we see here is the dose response associated between leisure time physical activity and risk of all-cause mortality favors being active. And there's also a dose response in terms of cancer risk, which also favors being active. And with cardiovascular disease, actually, looks like if you're all that active, it might be getting a little worse, but don't believe it. It looks like physical activity is better than doing nothing. And the benefit is already seen with as little as 50 minutes per week. That would be 8 minutes a day. And so I would advise you to get off the couch and be active. Then we'll finish with this case. 28-year-old Iranian suddenly becomes unconscious in the street. Somebody thinks he might be a drug addict, so he gets an naloxone, starts breathing again, but then he relapses again. And he seems to be relatively naloxone dependent. So he had a plain film of his abdomen. He's filled with these packets of material here. And in CT, we can see these packets. And this is an example of heroin body packing. And heroin body packing is discussed by these authors. But since they had to operate on him to take all these things out to save his life. But since the condition is treated with the death penalty in Iran, maybe the authors will give us a follow-up. That's it for this week. Thank you for your attention. And if you'd like to listen to all this in German, in 7 minutes, we'll do it. Aber dies war ein bisschen schwieriger. Ich glaube, auf Deutsch wird das auch ein bisschen länger dauern.